Welcome, ladies and gentlemen. In this video, we will be discussing Ehlers-Danlos syndrome type 3, hypermobility EDS. Hypermobility EDS is an autosomal dominant disorder. The gene associated with this type is unknown. Hypermobility EDS may affect many areas in the human body. However, in this video, we're only going to talk about 4 of them. Here I present to you the first 3 out of the 4. The joints, the skin, and the heart. Let's talk about what can happen to the joints in a patient with hypermobility EDS. The patient may present with large and small joints and spine hypermobility, chronic joint pain, and joint dislocations. If you can recall, in our classic EDS lecture, we mentioned 3 major joints that are most commonly subluxated in classic EDS. Those same joints are most commonly dislocated in hypermobility EDS. And they are the shoulder, patella, and the temporal mandibular joint. Now let's talk about what can happen to the skin in a patient with hypermobility EDS. To begin with, the skin will be soft and smooth. The patient may present with mild hyperextensibility of the skin. Keratosis pilaris. What is keratosis pilaris? Keratosis pilaris are spiny follicular papules with perifollicular erythema primarily occurring on the extensor surfaces. Let me translate. Keratosis pilaris are tiny red dots that arise from the hair follicles on these areas. Patients may also present with striae. Now let's talk about what can happen to the heart in a patient with hypermobility EDS. Patients may present with mild aortic root dilatation. Now, let's talk about the 4th site that may get affected in a patient with hypermobility EDS. The brain. What can happen to the brain in a patient with hypermobility EDS? Patients may present with what is called Chiari type 1 malformation. Now, before we talk about this, I want to go over some anatomy. Here we have the left cerebral hemisphere of the brain. Here is the brain stem, and here we have the cerebellum. The cerebellum is composed of 2 hemispheres, but for this topic, we only need one of them. Now, let's focus in on the cerebellum. This is our cerebellum, and this is the fourth ventricle. Within the cerebellum, we have white matter termed arbor vitae, meaning tree of life. Surrounding the arbor vitae are lobules. There are 10 of them. They are the lingula, the central lobule, the culmen, declive, folium, tuber, pyramid, the ovula, and the nodule. Surrounding these lobules are veins. We have the precentral cerebral vein, the preculminate vein, the intraculminate vein, the superior vermian vein, the inferior vermian vein, the superior retrotonsillar vein, and the inferior retrotonsillar vein of cerebellar medullary cistern. In between these two veins, and right under the nodule and the ovula, we have the cerebellar tonsil. And right under the tonsil is our foramen magnum. The distance between the cerebellar tonsil and the foramen magnum is what we will be referring to in Chiari type 1 malformation. The position of the cerebellar tonsils differs in each patient. In the normal healthy group of patients, the position of the cerebellar tonsils to the foramen magnum range from 8 millimeters above the foramen magnum to 5 millimeters below the foramen magnum, with an average of 1 millimeter above the foramen magnum. In patients with Chiari type 1 malformation, the cerebellar tonsils are abnormally shaped, and the position of the cerebellar tonsils to the foramen magnum range from 3 millimeters below the foramen magnum to about 29 millimeters below the foramen magnum, with an average of 13 millimeters below the foramen magnum. This may cause patients to experience headaches. Other things patients with hypermobility EDS may experience are irritable bowel syndrome, autonomic dysfunction, sleep disturbance, and varicosities of the legs. Now let's talk about how to diagnose a patient with hypermobility EDS. To diagnose a patient with hypermobility EDS, you need two things. You need major criteria and minor criteria. The major criteria for hypermobility EDS are hyperextensibility of the skin, joint hypermobility, and absence of the widened papyraceous scars and weak skin that you see in classic EDS. The minor criteria for hypermobility EDS are joint dislocations, joint pain, and a positive family history. Ladies and gentlemen, this has been my presentation for hypermobility EDS. I hope it helped. Thank you for watching.